Welcome, everybody. My name is Beth Feynman, and I'm so pleased to welcome you to this program. I'm like watching you enjoy your food, and I was like so jealous. But this is a Medscape Oncology program, and we are going to have an interactive program today, and we will ask you to use your own technology. Just about everybody has a smartphone today. So if you wanted to connect to the Wi-Fi network JADPro Live 25 and use JADPro 25 as the password, we'd ask you to scan the QR code. Now, if you can't do it right now because you're enjoying your salad or whatever you're eating, you can scan it on the tabletops. It's right in front of you. So this Medscape Oncology event is titled Advancing to the Next Level of Care with Bispecific Antibodies in Relapsed Refractory Follicular Lymphoma and Relapsed Refractory DLBCL. This is our lovely chair, Amy Goodrich. She is going to be presenting as well. I'm the host, Beth Feynman. I'm also joined by esteemed faculty Caitlin Murphy from the Dana-Farber in Boston, Massachusetts, and Ryan Homschild, who's a PharmD and Vice President of Pharmacy. He runs the whole department down there. Thank you for taking time out to spend with us in Atlanta, Georgia. So again, this is a game show style program, and you can win a prize. We won't tell you what that is. And I think we have a video to play. We're going to have 3 teams: confident clinicians, lymphoma leaders, Marilyn Masters, and Q. So did you figure out from that video what we're doing? That's for me to explain. So again, we're going to have 3 teams: confident clinicians, lymphoma leaders, and Marilyn Masters. We're going to have fast facts, administration answers, and a final question, level 5. So levels 1, 2, 3, 4. And this is meant to be fun and interactive, of course. The Onco Challenge will focus on topics such as round 1, fast facts; round 2, administration answers; 3, practice pearls panel; and finally, concluding remarks and audience question and answer. We're going to start to familiarize you with the polling questions, and this is just a quick, easy poll. How familiar are you with bispecific antibody use in lymphoma? I have no experience, I have limited experience, or I am very familiar. Great. So we have varied experience here. I have limited experience. You're in the right place. I'm glad you didn't go to the lung cancer talk next door so you can hear about this. At this point, I'm going to take it away. Amy.
Thank you, Beth. And thanks, everybody, for coming.
We have seats right in the front.
Okay, great. Okay, so let's start with a question. How many bispecific antibodies are FDA approved in follicular lymphoma? 1, 2, 3, 4, or no idea? That's why I'm here today. Okay, great. I love that most of you answered 5. So you're going to leave here knowing the answer. All right, so currently there are 6 approved bispecifics there have been 6 approved in the last year. Today, in the lymphoma space, they're CD20, CD3 targeted. Even though patients can have low numbers of these targets, they work, and this is the target that's being used today. There are countless ongoing clinical trials, so they're here, they're exploding, and hang on, because they're coming. So in diffuse large cell, we have, as of October, they are moving into second line. So historically, our epcoritamab and glofitamab were approved for third line and beyond. And recently, they have moved into second line with GemOx as options. And then mosunetuzumab, is not approved for diffuse large B-cell, but it is being studied widely. So likely coming at some point. But today, we've got epcoritamab and glofitamab. In the follicular lymphoma space, we've got 2 approved bispecifics. We have mosunetuzumab that's been around for a few years now, third line and beyond. It's finite therapy up to 17 cycles. And then epcoritamab, which is our open-ended subcutaneous bispecific in the follicular lymphoma space. So we've got 2 in follicular lymphoma, and then odronextamab is really the most mature in clinical trials and is likely going to be the next one that meets our FDA approval. So,
this is me,
Oh,
Fast
yes,
Facts.
thank you.
I get to do all of the questions. And so Fast Facts level 2, so you did the level 1, thank you
Sorry,
for doing
Beth.
that. That's okay, there wasn't a little purple thing on there. Bispecific antibodies are recommended in which line of therapy for DLBCL? First line, first and second line, or second line and later? So maybe you heard Amy give you the right answer a moment ago. It's kind of freaking me out they don't have a face. Does that bother you?
Yeah, and
They don't have any faces. I know. Yeah. Ooh, second line and later, 59%. The correct answer, Amy?
is second line and later.
There you go.
Yep, wonderful. So looking at our for first specifics, they're not approved. For second line, in the diffuse large cell space and the follicular space, we're using chemoimmunotherapy, we're using antibody drug conjugates, we're using chemo-free regimens, things like lenalidomide with an anti-CD20. And then in diffuse large cell, we can use our bispecific with GemOx in second line, CAR-T, transplants. And it's really third line where bispecifics are an open, anyone can get them. CAR-T comes in, and there are lots of other therapies that are available for both of these patient populations. So when we look at bispecifics in follicular lymphoma by treatment sequence, today there is no first-line option. Patients are there's in multiple phase 2 trials going on with all of these drugs and all of these lymphomas that we're talking about, both as single agent and in combinations. Second line, there is still no approval in follicular lymphoma second line, although it's likely coming within the next few months. And then third line is really where EPCOR and mosunetuzumab come in for follicular. So let's look at this phase 2 trial of mosun with lenalidomide in follicular lymphoma second line or later. And so this is a phase 1-2 study. They get IV mosunetuzumab and lenalidomide for 12 cycles, and with a maintenance option as well. And so right now, the preliminary data shows an overall response rate of 90% with 66% complete responses. And it's still recruiting, still ongoing, but there are some really successful and really exciting trials going on that look good at this point. Let's look at EPCOR FL1, which is a phase 3 open label looking at EPCOR with rituximab and lenalidomide compared to R squared. So EPCOR with R squared versus R squared. Again, this is in patients previously treated follicular lymphoma. You can see the arms here. There are a couple different doses of epcoritamab in arms 2 and 3, but basically it's a 2-drug versus a 3-drug. And this is active, not recruiting. Interim results are expected soon, and so this may be the next combination that meets our NCCN guidelines in the follicular lymphoma space. So what about diffuse large cell? So again, nothing in first line today, lots of studies going on. In second line, so currently if you look at our NCCN guidelines, in patients who are not CAR T candidates, using epcoritamab or glofitamab with GemOx, and then there's also an option of mosunetuzumab with polatuzumab, which is a really exciting non-chemotherapy option, and again, lots of trials going on. And then it's really where in third line, you can use these, as single agent.
Absolutely. And here's our Onco Challenge question number 3. We're up to level 3 already, so thank you so much for participating. Again, if you're just coming in here, you need to scan a QR code on your table if you have a table. Sorry, people on the right over there. But thank you for coming. You can scan the QR code to join, and we're going to ask that you answer the questions so you can win a prize. So follicular lymphoma should be hospitalized in a 23-hour observation unit to receive a bispecific antibody. Is this true, false, or who has the bed capacity for that? This is a level 3 question.
There should be 2 options.
There should be 2 options. Hi, Laura. Let's see. True, false, or who has bed? Oh, somebody answered that one. Thank you.
Okay. Great.
That's the correct answer, is false.
All right. So let's just look quickly at this slide. And at the top, it says no hospitalization for follicular lymphoma. So there is hospitalization for diffuse large cell, not for follicular. So if we look at Mosun, which is approved in the follicular lymphoma space, all outpatient, and you can see 4-hour infusion going down to 2-hour infusions, all outpatient. So epcoritamab, and we're going to talk about dosing. The dosing is different. There's an additional step up. There are 3 step ups before full dose in the follicular space. And so that has allowed all outpatient administration of EPCOR in the follicular lymphoma space. For glofitamab and epcoritamab in the diffuse large cell lymphoma patients, you can see that there is an admission. It's different for EPCOR than glofit. So epcoritamab, it's the 3rd dose, which is the first full dose that admission is recommended. And for glofitamab, the week after the lead-in with obinutuzumab is when the admission is recommended. And you can see here, Mosun is fixed, 17 cycles, epcoritamab, open-ended, glofitamab is a 1-year, 12-cycle therapy. So I alluded to this, and this is, I'm not going through this in great detail. Really what I want to put your eye on is, I don't know, this is glitching out a little, sorry. What I want to put your eye on is what's highlighted here, that there is an additional step-up dose for follicular lymphoma that makes this an all-outpatient regimen, which is great. There was a lot of CRS when they modeled the diffuse large cell ramp-up, and then the additional dose really reduced the CRS.
Onco Challenge question number 4. 3-year follow-up data with bispecific antibodies in DLBCL demonstrates which of the following? 1, an increase in cumulative side effects, 2, durable responses at 3 years, or 3, emergence of treatment resistance in certain patient subsets. Ooh, this is a tough one. How would you answer it, Amy? There we go. Durable responses at 3 years. That is the correct answer. Good job.
It is the correct answer. And my thing is failing. I promise you I'm not going to sing.
Oh, that one. Perfect.
Okay, great. So let's look at epcoritamab trials. So this was EPCOR NHL1, which it was 3rd-line diffuse large B-cell lymphoma. And so you can see here, this is really the FDA approval. This was the pivotal trial for diffuse large B-cell lymphoma in 3rd line. So you can see, getting tight in cycle 1 and then every 2 weeks and then every 4 weeks, just like we're giving it. This is our standard of care regimen. But these were patients who, had lots of prior therapies, and this was one arm of the study. And so what did this show? Why is this drug approved in the diffuse large cell space? This is 3-year follow-up data, and you can see those curves, and it doesn't even matter what they are because they're all overlapping. But really, the bottom line here is median duration of response is very good at 20.8 in the large B-cell lymphoma space. And if you look at the transformed lymphoma data, not reached yet. So this drug is really very good for both of these patient populations, but certainly for both de novo diffuse large cell and our transformed folliculars. What about glofitamab? So again, this was the pivotal trial. So this is exactly how we're giving glofitamab today. You get a dose of obinutuzumab, you get a couple smaller doses, and then you get up to the 30 milligram dose, maximum 12 cycles. Again, heavily pretreated diffuse large cell patients. And what are we seeing for GloFit at 3 years? So we are seeing that overall response rate of about 80% and progression-free survival at 2 years. You can see that's a 24-month time period on the graph, is just under 63%. So in patients with CR, of course, those do better. That's the top blue line. The others are patients with PRs or no response. So those folks who get a CR tend to do best. And I think that's really true of just about all therapy we give. All right, so let's look at a phase 2 expansion study of Mosun in relapsed refractory follicular lymphoma. And again, this was the pivotal trial. Follicular lymphoma patients, lots of prior therapies, and giving it exactly the way we do today, 1, 2, 60 for a couple, and then at the cycle 3 down to 30 milligrams. So this is exactly how we're giving this today, up to 17 cycles. So with Mosun, you restage after 8 cycles. If people are in a complete response, you stop. If they're not in a complete response, you go to 17 cycles. So let's look at 4-year follow-up in Mosun in follicular lymphoma. And so responses were definitely durable. Time to next treatment, 55 months, almost 56 months, which is just spectacular in a heavily pretreated group of patients. So PFS, progression-free survival, overall survival, of course, like in the diffuse large cell space, higher in patients who get a CR, and 64%, 42-month progression-free survival, and almost 94% overall survival. And then efficacy was durable even in patients with these high-risk features, things like progression of disease within 24 months, bulky, elevated LDH. Although their progression-free survival was shorter, it was still very favorable.
Wow, look at this. The leaderboard, confident clinicians, 3255, lymphoma leader, 2998, and Marilyn Masters, we got to step it up, 2834. This is exciting, though. I don't know what those points mean. It seems like a lot of points, but you're doing great, so keep it up. Thank you so much for that overview. I'm just so excited to see these long response rates in these patients that have been heavily pretreated, especially with those high-risk bulky disease.
Yep.
It's something else. So we're going to go into the next round, administration answers, and we're going to start with an Onco Challenge question. Caitlin and Ryan are going to be presenting the data in this area. Level 1, in follicular lymphoma, the third step-up dose is the full dose. Is that true or false? So those of you that haven't scanned the QR code, maybe you can help out Marilyn Masters. You should have been a team. Yeah, you should have been a team. We would have actually probably gotten them all right, though. And that's not fair. Unfair advantage. I love game shows. I still watch Jeopardy all the time.
I know I do too.
Never disappoints. Survey says true, 71%, false, 29%. We're going to fix that, right, Caitlin and Ryan?
That's
Okay.
right.
Here we go.
Well, I don't know if it's true, but I'm on the left, which is the confident clinician, so keep up that good work, team. But we'll transition now into the work. And I think here, this is the important piece to call out, is there is different step-up dosing between follicular and diffuse B-cell lymphoma. And if we're seeing here, you can actually see the step-up doses are actually going to the 4th dose here. And so in epcoritamab, you can see that we're stepping up day 1, day 8, day 15, with kind of that maintenance dose that's continuing on the 4th dose and beyond. The same with mosunetuzumab, where we're starting to see that step-up dose, and then cycle 3, day 1 plus, we're seeing that 30 milligrams. So you are seeing different dosing strategies between follicular and diffuse large B-cell lymphoma, and I think that's just a key area to call out here. Have the 4 for follicular and the 3 as we transition to the next slide, really focus on diffuse large B-cell lymphoma. Some of the differences that my colleagues called out earlier also have to do with hospitalization, right? So in follicular, there's not going to be a hospitalization requirement. However, in diffuse large B-cell lymphoma, you are going to see more of that hospitalization recommended for epcoritamab on cycle 1, day 15, where you see that full dose, and then glofitamab, seeing that really in cycle 2, day 1, or sorry, cycle 1, day 8 for that hospitalization. But really the difference here is we have a 3rd dose is really the max dose in diffuse large B-cell lymphoma, and we're going to see 4 in follicular. And keep in mind too, with this hospitalization, this is the package insert. Many people are adapting this model to their institutions, and I think that's an important call out as well. So when we think about bispecific antibodies in lymphoma, I kind of get excited because this is where the technology is headed, right? This is where we're giving really durable responses that we saw in the data earlier. So when we look at mosunetuzumab, we see in follicular that hospitalization is optional, right? And we see that based on the package insert. And one of the key callouts that I always try to think about is what is the time to CRS? And what does that look like when we're treating a patient? So if we have a patient, maybe we're treating at an academic center or community center, what does that duration look like of onset, and how do we prepare for it? We look at epcoritamab, we have follicular and diffuse large B-cell lymphoma. And if we focus in on diffuse large B-cell lymphoma first, kind of brings us back to that hospitalization on cycle 1, day 15. With follicular, no admission recommended. And so that's something that you can be doing outpatient to manage that patient. But keep in mind, CRS around 2 days, but there is a range there as you're preparing your program to make sure how can we be successful in transitioning this into the community or the outpatient setting. And then lastly, we have glofitamab with diffuse large B-cell lymphoma, cycle 1, day 8. And here we see just beyond a day, right, about 30 hours, but keep in mind there is a range there that we need to be consistent. So how do we draw upon not only when the hospitalizations occur, the indications, but that time to onset, and how do we build that into our protocols, leveraging some of the package insert data?
And here's our Onco Challenge question number 6, level 2. Pre and post medications can vary by bispecific. True or false? Please answer the question. Kind of wish there was a little diversity in this Maryland lymphoma confident clinicians. They keep looking so pensive, right? Not that hard. Why am I so fixated on the characters? I don't know. Fill out the comment question with your post survey and see if you like these graphics. True, great answer, 90%. Ryan?
Well, way to go, team. We're all in this together. So we will now transition to the next slide, really looking at pre-treatment, right? And I think this is where we play such an important role because we want to set that patient up for success. And a lot of that has to do with pre-treatment. Do we have the right pre-medications? Is the right hydration in play here? And then ultimately, how does that monitoring continue to evolve? So let's jump in a little bit further and talk about the pre-treatment in a little more detail. So we see the bispecific antibody pre-medications. And so if we look across the board, we start with an antipyretic. So for mosunetuzumab, we see that we can use Tylenol about 30 minutes prior to cycle 1 and cycle 2. Epcoritamab, we see a little bit more of a range of dosing and time to treatment, right? So here are some of the differences. You might call them slight differences, but I think they're important to call out, especially as you're building your treatment plan in the EMR or your protocol. And then we have glofitamab, right, where we're focusing on 500 to 1,000, and it can be 30 minutes before all treatments. Next, we want to think about our antihistamine. I think about this a lot. Many of us are familiar with infusions. Usually an antihistamine is given, not too much of a surprise that it is a first generation, but here we see diphenhydramine. 50 to 100 milligrams, 30 minutes prior to cycle 1 and cycle 2 for mosunetuzumab. For epcoritamab, we see it just before cycle 1, and we see it about 50 milligrams, and again, have a little bit more of a range there when we're looking at treatment. And then lastly, for glofitamab, we're going to do that 50 milligrams, 30 minutes before all infusions. And then I think really the detail that I like here is focusing on the steroid, because this prophylaxis can really set our patients up for success. And so when we look at mosunetuzumab, we see dexamethasone 20 milligrams, or you can use methylprednisolone 80 milligrams, and this is going to be about 1 hour prior to treatment. We really want to make sure we're building these protocols in. That's why they're in the package insert, to make sure that we're reducing any reactogenicity that these patients may have. In epcoritamab, we're seeing a lower dose of dexamethasone, a broader range, and that's cycle 1 treatments for 3 consecutive days. And then we'll continue, obviously, if there's CRS, grade 2 or grade 3. And then finally, for glofitamab, we're focused on the dexamethasone. So 1 hour before treatment on that cycle 1, day 8, 15, cycle 2, day 1, cycle 3, day 1, and then really beyond there, only kind of if there is CRS. So those are differences. They might seem slight, but as we're building those treatment plans or protocols, it's really important that we stay on top of these slight differences to make sure we're setting our patients up for success. So how do we start bispecific antibody therapy and logistical considerations? This is something we talked about a little bit earlier, is to set up a program that's successful. Not only do you want to set it up for maintenance dosing, but you want to set it up for step-up dosing. And many of us in the room, right, we comprise community, academic, maybe local regional hospital groups. And so we want to make sure our program is sustainable for all patient types. And so first, we got to make sure we start with the personnel. I've got amazing colleagues up here, amazing colleagues where I practice, but you want to make sure there's a team that's in place here to monitor these complications. Because the worst thing you want is you get a patient going on a great therapy, great durable response, and then they have a CRS, and there's no program in place to manage that patient. And so here, we want to educate. What does ICE criteria look like for monitoring? What are our protocols that are going to be in place? How do we educate? That means our physicians, our APPs, our PharmDs, our RNs, really everyone that's caring for that patient throughout that continuum. And also, how do we partner with someone? So I think about an academic medical center. Is there a hospital nearby that if we do have a patient that has a grade 3 or above CRS, that they can be seen? Are they going to have that tocilizumab there on site? Are they going to have the protocols and education to stabilize that patient and get them back on treatment? And so to me, I think what this whole group is about is interprofessional collaboration. So think about it this way. How do we not just educate ourselves, but the caregiver and the patient as well? So I always think about this way. I want to set that patient up for success when they come into the office or for treatment. And so what does that involve? I think number one, being very proactive. Here's what you could expect. Here are the side effects that might be associated with the treatment. And here's early identification. And you're going to call us, and here's the steps that you're going to provide. Home monitoring and education is key. Inviting that patient into the discussion with us will set them up for success. There's nothing worse than delayed recognition of CRS, and then that patient has to end up in the emergency department, an inpatient stay, or potentially delays in treatment. So how do we identify early, get early intervention, and make sure that they have a thermometer, make sure they have a blood pressure cuff? Do they need a pulse ox? How do we make sure that they have prophylactic medications on hand, like dexamethasone, if something is to occur? And then lastly, make sure they're near a facility or they know where to go, and that facility has appropriate tocilizumab if needed, so that they can have the ability to best manage that CRS. And I think lastly, that's that facility. How do we get insurance authorization? Make sure it's sustainable. We have that supply, remember, 2 vials per patient for toci. I'm sure everyone here remembers that, but it's not a bad call out. And I think lastly, creating those standard order sets. How do we partner with that hospital, our practice? So when CRS occurs, it's not a scramble to say, what do we do? Where's the package insert? But that data is readily available, and that treatment plan can be released so that we can make sure that patient's taken care of in a timely manner. I think lastly, we want to make sure that bispecific antibodies are having that pre-treatment preparation from a laboratory monitoring perspective. So how do we make sure we have the CBC, the CMP, and the LDH? Do we need a MUGA scan? Is there any cardiac monitoring that's involved for this patient? How do we define that criteria on the front end? And then lastly, making sure we're including hydration. These are key steps that set the patient up for success, but also as clinicians, allow us to get really great outcomes. We talked about pre-medications a little bit earlier. Follow that manufacturer labeling. Dexamethasone is a preferred agent. It can reduce that incidence of CRS, and we've seen this data coming out at ASH recently as well. And then before or after administration, if no CRS is occurring, then we can probably stop some of these pre-medications. And then, depending on the patient, infectious prophylaxis could be needed. And then lastly, outpatient considerations. Again, we're shifting care to the outpatient environment. Hopefully that's a theme that will continue to merge throughout the conversation. And that means, how do we identify that facility that has an intensive care unit, that has tocilizumab, has the expertise of the clinicians, so if that patient shows up, they're not stuck in the ED and no one knows how to work them up for CRS. Or if they get admitted, they're not wondering, who do we consult and how do we manage it? These are all things that can be solved for on the front end that create really more of a seamless patient handoff and experience.
Thank you, Ryan, for such I want to give you a clap. It was such a great overview of all those steps that are involved, my goodness. And so hopefully these drugs are designed to be given in the community, so hopefully that's where we're moving, is outpatient. So in clinical practice, this is our level 3 administration answers, and thank you for answering these questions on your QR code and on your app. In clinical practice, the CRS rates are similar to clinical trial rates. True or false? Unique about this conference is that Ryan is a PharmD, and we have advanced practitioners on the panel as well, and the different perspectives that all the advanced practitioners bring to the table. True or false? False, 37%. Interesting. All right, well, let's go to Caitlin. Let's talk about bispecific antibody pre and post.
All right, so now you're in a well-prepared situation. Your patient knows what to expect, your team knows what to expect, you have great data, and you know that this is the best therapy for your patient. So we're gonna kind of go into when they're actually experiencing this treatment and how are we monitoring them so that they continue to be successful. So when we think about safety considerations in the setting of bispecific antibodies, we think about our hematologic toxicities. Obviously, this is very prevalent in our patient population. Hypogammaglobulinemia and neutropenia are the most common occurring heme toxicities. We think about infectious risk. We'll get kind of into that, just understanding the immunological function of these therapies. Neurotoxicity can be terribly devastating, really scary. Same thing with CRS, but I will kind of give you the heads up, it's not as daunting or scary as I think what we think in our CAR T-cell therapies, which makes this a really great option to be given in the outpatient setting. So when we think about CRS grading, starts at that grade 1, that kind of initial fever. Grade 2, we start to see some changes in their blood pressure, maybe a little bit of need for a low flow oxygen. Then we kind of tiptoe into that grade 3 where we really are adding a lot of additional support, vasopressors, they're on high flow. And then grade 4 is really when we're starting to see some concerning hypotension and really a need for oxygen support. So keeping that in mind as we kind of move through the grades. So when we think about the bispecific antibodies, when we think about diffuse large B-cell versus follicular, there's incredibly different grading in the incidence that we see, but I think the general thing that we see in clinical practice is it's significantly lower than what we saw in the clinical trials experience. And I think also as a call out, when we look at these grade 1 or 2, these are things that you can really readily manage in an outpatient setting, even conditionally at home if you really are in good touch, if the patient's really engaged, they've got the right care support. So when we think about Mozu in the diffuse large B setting, grade 1 or 2, yes, 42%, but really low in the incidence of the higher grades at the grade 3, 4. In epcoritamab, once again, around 50% in the grade 1, 2, and then once again, really single-digit numbers in that grade 3 and no grade 4 CRS. And then glofitamab, again, kind of in that 50 to 60% with the grade 1, 2, and then single digits at 4% in the grade 3, 4. So these are really aggressive subtypes. These are patients that have been previously treated, and they're really able to manage and tolerate these therapies. In the follicular side with the mosunetuzumab, much smaller in terms of low grade, so grade 1, about 25%, and then obviously much lower in the 3, 4, and that carries through with the epcoritamab as well. But rates in clinical practice very much lower than what we were experiencing in the clinical trial space. So when does this happen? So I think Ryan did a great job of, if we can be the best prepared, we can anticipate, we can coach, we can tell patients, we can kind of know, oh, I'm gonna get a phone call tomorrow, I'm gonna get a phone call tonight, when these things are gonna happen. So CRS occurs with epcoritamab most commonly in that first full dose. So remember that we were doing a step-up dosing, and so you're going to see it on cycle 1, day 15. And so that's where, you know, the consideration for hospitalization is for our diffuse large B-cell patients because of that high risk. And so how do we well prepare and support that patient population? And a very short duration of 2 days. So that's where you know you can kind of follow them closely within that window. But this is the other tip-off. If they start presenting with that fever, think of something else if it's not in that window. So when does CRS occur with glofitamab? So a completely different product, but in the diffuse large B-cell setting, it's in that first dose that they receive. So they often will get that cycle 1, day 1 with the obinutuzumab. They'll kind of debulk, but not necessarily does that eliminate this risk. And so we're still seeing a fair bit of CRS in that first dose, and which is why they're hospitalized. With mosunetuzumab, that is the third dose, that it's going to be the most common, and so that's where we're seeing that cycle 1, day 15. Once again, you're kind of preparing them. You're still telling them that it can occur at their first cycle, day 1 or day 8 or day 15, but day 15 is when you kind of have your guard up and you're ready for that phone call. You're ready to actually intervene when they're calling with symptoms.
And I just wanted to point out, I think all of these slides are available for you to download afterwards. There's so many clinical pearls in here, so thank you for sharing that overview of the onset of CRS. It's so confusing, and I think it's just so unique, and that's why real-world studies are something that advanced practitioners can do that really look at the data and do chart reviews and see who's at risk for CRS events. So the Onco Challenge question number 8, level 4, how much tocilizumab do you need to have on hand in the hospital? Ryan told us the answer to this question. Who was listening? 2 vials, 4 vials, 1 per patient, 2 vials per patient. Please answer. Survey says 2 vials per patient. Yay, 59% got it correct. So good job, everyone. Caitlin?
Excellent. All right, so when we're thinking about tools for our management of CRS, as I mentioned, in that low grade, there's often times that we can give them Tylenol, acetaminophen, monitor them, hydrate them really well, and have a really close monitoring plan. And then we consider dexamethasone if they're refractory, or if the timing of when that fever occurs, if it's really early onset, there's a consideration that dexamethasone is indicated a bit earlier. At that time, do we say, you know, does the patient need to come in to be evaluated? I think that's where, when you're preparing for these therapies, is there an opportunity to bring them into clinic, avoid an ED visit? Is there an opportunity to keep them home for a little bit longer, get them through the night, and then bring them back first thing in the morning? But then there's also the consideration when we really do need to still consider the CRS profile and have tocilizumab on hand. And early TOSI after a trial of dexamethasone can be indicated and considered, especially if you have someone who has a couple of other extra comorbidities that you're concerned about. So I don't want to belabor this too much, but hopefully this isn't something that's new or different to a lot of you, but that first grade 1 of CRS is fever alone. So that's the only thing that they're presenting. And you're really confident that this is the only driving reason why they would have a fever. Grade 2, that's where you have fever. You can have a little bit of hypotension, but you're not requiring a lot of engagement with vasopressors or additional support with fluid resuscitation. And then it could potentially have some hypoxia. And as the grade goes up, you're adding those layers of those side effects and symptoms. So when we think about management, we think about grade 1, that's going to be the most commonly occurring thing. So when we think about it, we can observe them, we can give them a little bit of acetaminophen, we can also consider tocilizumab depending on the time frame. As it kind of goes up in grade, that's when we start layering in some of these additional therapies. That's when we start thinking about using tocilizumab, and then potentially use steroids as we get further along as the grade goes up. When we think about neurotoxicity, this is also incredibly rare, so this is a little bit different. This is where their cognitive impact is being changed, and so they're not necessarily mentating appropriately. They may have a little bit of confusion. Maybe they aren't able to name everything, follow small commands. But as you can see, really, really incredibly low incidence of this. And so I think this is why people have a lot of comfort in having this off-the-shelf product in an ambulatory setting, because it is quite safe to be delivering. When we think about neurotoxicity, we're thinking about ICE scores, and so alluding to how we assess that in terms of cognition, looking at having them name person, place, or thing, following short commands, left hand, right ear, so that you can assess their cognition. And we're starting with utilizing steroids. So that's really where the front line for neurotoxicity and management is utilizing the steroids.
Onco Challenge question number 9, level 5. Your patient was hospitalized and missed their bispecific dose. What is the correct course of action? 1, it depends on the length of time since the step-up dosing. 2, nothing, they resume the same schedule at the same possible. And 3, I have no idea, please educate me. How many 3s are we gonna see? I think this is a big challenge in clinical practice. People take vacations, they are hospitalized, and life happens. And so I'm interested to see how people respond to this question. Survey says, it depends on the length of time since the step-up dosing. Absolutely, 100% correct. Caitlin? Oh, no, I think we're back to Ryan. We're back to Ryan, yes.
Listen, I'm excited to jump in on this one. My pharmacist at Roots here. So you are correct, right? It totally depends on when that patient had their last step-up dose. And I think that's an important piece because, like you mentioned, life happens. Every patient's different, depending on how frail they are, how advanced they are in age, where they live, transportation vulnerability. These things come into play in our practice. And so treatment interruption may require initiating step-up dosing again. We know step-up dosing requires, right, very close oversight, higher risk of CRS, as we learned earlier, pre-medication, making sure we have that facility by. And then also, you're going to have guidance based on your treatment center in terms of holding patterns, because there are different patient, I think, factors that come into play. Looking at ECOG status, again, frailty, looking at the treatment time. And then you want to maintain that schedule as long as possible, right? And we talked about this. Setting our patients up for success on the front end really pays off, because these therapies, they are transformational. They are providing high overall response rates. And so how do we make sure that we maximize compliance for that patient and also keep them out of the ED when possible and manage those symptoms appropriately? So there's going to be a quiz on this at the end of the day. So please, go ahead and I'm just kidding, even though I know the confident clinicians would come through for me. So I think really what this gives you an idea, though, is it is a little bit more complicated, right? And so if you're not seeing these patients on a day-to-day basis and you have a pause, you're going to need to go to the package insert, or you're going to build this protocol into your EMR, into your practice, so that you have this information readily available, because it is important to follow, right? So depending if it's been 1 to 2 weeks, greater than 2 weeks, someone went to Europe and it's greater than 6 weeks, right? All of this will play into where you restart this patient at what dose you restart them. So don't memorize this, even though I said you needed to. I want you to have a takeaway that it's really important to reference the package insert, be prepared, have this built out in your order set. So when it comes to looking at that last date of treatment, you can easily navigate and get that patient back on track. The same goes for diffuse large B-cell lymphoma for epcoritamab. I would say this one's a little less complex in my opinion, but I think at the same time, you want to make sure there's actions for each dose and you're following those parameters. And I think having this front-facing to clinicians, your patients come in, you're doing cleanup workup the next day, you're recognizing there's been a delay, the infusion center calls you, you're ready to kind of redose this patient and get them back on track. Or let's eliminate having to get them back on track and let's keep them on the schedule so they're getting that durable response. That's probably the key takeaway out of these slides.
Well, now we're into round 3, practice pearls. That means we're in the last part of our session. Now, these do not have any audience response, so you don't have to, but these are just kind of panel discussion questions. So what is the main caregiver concern about bispecific antibodies? Is it no driving for 2 weeks, neurotoxicity symptoms at home, hospitalized duration, CRS monitoring, or duration of response? And I don't even think they answer these questions, right? What do you think, Caitlin, from your perspective? What do you hear a lot of?
Yeah, I think the piece that probably impacts our practice the most is that CRS monitoring at home. I think that there's a lot of onus on the caregiver, and I think on the familial support. These are great off-the-shelf products that we can kind of have far-reaching, but it does require a lot of collaboration with caregivers. And so giving them that education and having them feel confident that they can make the right call. Most times I just tell patients, if anything's different, just call us. We'll kind of sort through the weeds, but it's really important for them to still have that caregiver support.
And Amy, I want to hear from you too.
It's the same thing. It's that CRS monitoring, and the real luxury is when you have people getting bispecifics after CAR T, because then you can say, oh, this is going to be a piece of cake.
Yes, you've been well trained already.
Yes.
You already know what to look out for.
Yes.
Exactly. Oh, going back, we went too fast on this one. I think we want to have more of a discussion on this next one here. Do you have a bispecific antibody protocol for long-term monitoring? Yes, no, or sort of. We have adapted the CAR T-cell protocol. So Ryan, tell me what you do at your institution. Do you have a long-term monitoring, like a survivorship care plan for your patients?
You know, it's something we try to incorporate into the treatment plan. I will say, as you probably saw after you get through those step-up dosing and you're on maintenance, that risk of CRS drops really significantly. But keeping in touch and educating patients on the front end, like my colleagues talked about earlier for the step-up doses, I think plays into the long term. I will say if something changes with a patient, maybe there's an infection, maybe for some reason there is a delayed CRS beyond those initial doses, having an intermediate care center and a process in place where that patient can approach your institution immediately and not have to wait in the ED has really been a game changer. And I mean, we really are adapting these bispecific antibodies, not just in diffuse large B-cell lymphoma and follicular, but even the plasma cell disorders like multiple myeloma. And so I think building out this infrastructure of care, I think as we treat more and more patients or we do post-CAR T, you may see some delayed CRS, right? And you want to make sure that there's a pathway for those patients for long-term monitoring, that it's not just keeping them under watch maybe in those first couple cycles, but it's a long-term process as well.
What about infection monitoring afterwards? So what are some of the strategies you do in your practice for folliculars or diffuse large B cells? Because in myeloma, almost everybody's on shingles prophylaxis, PJP prophylaxis, and due to the hypogammaglobulinemia, we have a lot of IVIG needs to be administered. What are some of the supportive care strategies? Amy, maybe you start.
So it's the same thing. We do prophylax, PJP, and we use acyclovir or valacyclovir as well, and watching immunoglobulins in our bispecific patients, it's really the same. And if you think about your CAR T monitoring, it's very similar. Although the infection risk in the lymphoma patients is not like the myeloma patients, it's still real, and they need prophylaxis and they need monitoring.
What are your recommendations for immunizations these days? This is a hot topic in the flu season, and then we have some controversy at a larger level. Who wants to take this question of immunizations, Ryan or Caitlin?
I'll jump right in. I think that there's some immunological functioning that we're not quite sure how well people will robustly respond to vaccines, but I think in this arena, any bit of benefit is going to be quite beneficial. I also think that there's a lot of co-infection that tends to happen, so we're looking at flu and COVID, and then you mix in a little rhinovirus and RSV and a routine cold, and that can be pretty catastrophic for this patient population. I think tying in that long-term monitoring component too is that this risk doesn't go away the minute the drug stops. So when we think about B-cell aplasia as that long-term monitoring, we think about it more in the CAR T setting, but there is some immunological effect of the CAR T cell, of the T cells that we're thinking they're not necessarily going to have this robust immune system. Unfortunately, the understanding that this is how the lymphoma developed, we're well past that, but now we have all of these other considerations. So I think, a lot of prophylaxis, a lot of vaccines, a lot of gamma replacement, and once again, just routine re-education, that this doesn't just happen within this window of their episode of care, especially for these finite therapies. Indefinite, you can kind of keep coaching and they kind of get it, but these finite therapies, the risk doesn't end immediately.
Yeah, and we're recommending the seasonal inactivated influenza vaccine for everybody. RSVs once. I get that question a lot. How often can I get RSV? And then the pneumococcal vaccination as well. We do have of varying practice patterns, but I think those are kind of like the common ones. If you're over 50, you're supposed to get the shingles vaccine. I need to get mine, so I have to do mine too. Not only our patients, but them. But any other thoughts on the topic of long-term monitoring from the panel?
I just think it's an important piece of any program, right? Because a lot of us, we're not just looking at these indications in a silo, and we're going to see more bispecifics coming, right? UVL melanoma, there's a lot of different areas. And so I think follicular and diffuse large B-cell can be that catalyst to building out the program. But that investment, right? And this is me speaking from that pharmacy leader perspective, there takes investment to stand this up. But I think it's going to pay off. And we're seeing these therapies come in earlier lines, even though some of the data is not published yet, but we have an idea that it may get there. And I think you're going to see a lot more broad spread of patients, and you're going to have a lot more, I would say, refractory patients, earlier line patients, younger patients. And so I think having a long-term monitoring protocol outside of step-up dosing will just greatly strengthen the cancer program and reduce the need to refer patients out. And I think that's one of the big takeaways.
And I think the last on this topic is coordination of care. It's a huge thing because many of us work at larger institutions and we might start them on the bispecifics and roll it out to the community. So do you have any clinical pearls or recommendations from Amy, Caitlin, or Ryan on best practices for partnerships with community and academic centers?
I can go ahead. We have regional campuses, which I think is kind of dipping a toe into that partnership where you're kind of still within the big structure. But we often will do it after they've had that first full dose so that they've really successfully gotten through that and patients feel really confident. And so there's always this we call it a shared care model of how we can execute these patients to be closer to home, have less of that burden. I talked a little bit about caregiver support and the impact that has on these patients, especially when they're younger. We often think about our older adults, but we have a lot of young patients with families and things like that. So anything that we can do to kind of keep their quality of life as best as we can, because we want them living decades with these diseases. We're not there yet, but we'll get there. So I think that's a great thing that we can offer.
Absolutely. All righty then, let's go back to managing infection risk. We led into this already.
Yeah, no, it's all right. We all kind of shared the show on this one. So I think in terms of prophylaxis, as we've all mentioned, HSV, VZV, really concerned about shingles infections for this patient population, PJP prophylaxis, and then obviously vaccinations. And then, I think some of the considerations is utilizing some growth factor in some of these patients who have this prolonged neutropenia. This is a patient population that's heavily pre-treated. You have no idea what their marrow is, if it's still really quite functional. But those are things that you really want to be mindful of watching. If those neutropenia or any of the cytopenias really persist, to be watching their marrow and potentially doing some of those things. And steroids. Steroids. It's the backbone of all of our therapies. I think we don't necessarily recognize how wonderful they are in lymphoma. They are the backbone of our therapy, but they can be a real crux and a real problem with infectious complications. So, we want to keep people off, not having CRS or neurotoxicity, but we really need to dial it back when we can. I think that's a huge clinical pearl to remember, that you really want to stop steroids because it's only going to potentiate some of these infectious risks. When looking at the therapies, and Beth, you mentioned the multiple myeloma population, our infectious risk is significantly less in our bispecific program. So not to say that they're nil, but I think if we have experience on both sides, we kind of favor that we have less of those risks of the grade 3.
Practice pearls. Your long-distance patient will be starting a bispecific antibody at the University Medical Center. When is the best time to transition to the community oncology practice? First dose, step-up dosing is completed, after the third maintenance dose, or depends on the patients? And this is a panel discussion question, so you don't have to answer it. Amy, when do you transition?
I like B and D.
Yeah.
Right? Because it does somewhat depend on the patient. whether they're going to get on autopilot or what kind of complications they've had. But typically it's once you get them on the full dose and they're tolerating it, patients are safe to send back to the community.
And we want them to get this in the community
Yes.
where they live. We don't want them to have to drive to Johns Hopkins, where it took 2 hours for you to drive
Right.
today
Right.
to come down
Right.
to here. Caitlin, how fast do you transition back?
Yeah, I think that I would agree that the step-up dosing, I think there's just a lot more robust resources for that small patient population that may run into those higher grade CRS neurotox. And I think there's just a token of comfort with CAR T experience for some of these centers, but really, as soon as we can, we really want to get people back to where they can enjoy their lives.
And I think Ryan Emery shares the same model of trying to partner with the community and not keep them. We don't want to keep your patients. That's always the biggest concern, is that the communities don't want to send the patients to the academic centers because we're never going to give them back. But that's not true. We don't want your patients.
Yeah, I mean, I think you call it
Plenty.
a great comment, though, because I think sometimes that can be a barrier, right?
Yeah.
Like, why would I give this patient away and we're going to keep the patient? And so one of the great things we've really recognized is creating a memorandum of understanding between that community practice and the academic center. Hey, we might keep that patient for 3 maintenance doses just as a way to cover if there's a extended length of stay or a DRG that went negative. But for the most part, our goal is to hand that patient back. And honestly, how do we build that community partner so that you can start to do even maybe potentially step-up doses? Like, we're doing majority of all of our step-up doses outpatient. How can we build the infrastructure? If you need our intermediate care center, you have that available. How do we create some of that affiliation that builds the practice? Because like my colleagues have said, the majority of these patients are in the community. And we're doing okay on patient volumes. We'll always be willing to help, a lending hand, but I think the more that you can retain that patient and allow their care to be treated where they live, I think is where we're headed. And I tell my community oncology colleagues all the time, like, bispecifics aren't going away. So putting off building this infrastructure, this protocol, this on-call schedule is only going to get worse as these therapies move up in earlier lines.
Yeah, absolutely. And so building that rapport with the referral institutions, I think, is super important. And once, if you help one patient, then I think it'll benefit other patients as well, right? The next slide is going to be back to Ryan.
We just kind of talked about this, but I'm kind of excited to share this pathway again, because I think this slide is so key to setting up a program. And I think the first becomes patient selection, right? So we've heard about CAR T and cell therapy, and there's a patient selection that goes into play, but also you want to be thoughtful of the patients that we're doing here. So initially, what is that patient's fit status? What is their ECOG status? What is their tumor burden? How have they reacted to previous therapies, right? These aren't first-line agents yet. So they are going to be a pre-treated group. And what are their comorbidities? These come into play significantly when you're identifying what's the most appropriate patient to treat. And then lastly, what's the social support look like? We talked a little bit earlier about caregivers are truly partners in care, especially when they get home. So how are we engaging them, preparing education, or do they not have caregiver support? They live far away. And what do we do in those scenarios? We even look at the patient zip code, and you can actually look at their transportation vulnerability based on where they live, and we can incorporate that into the care that we provide. I think from there, it's that patient education, which you all saw me hit on earlier. I don't want to go too long, but I think providing that education on the front end gives them the tools to be successful. And then we have the drug administration, making sure that we have the sterile compounding facilities, we have the protocols in place, the order sets. If someone comes back after 6 weeks, what do? We know what to do because it's right there in the order set, right? We have the pre-meds, the hydration, all of that built together to set us up for success. And then it comes in that self-monitoring, right? Because we know the difference between some of the cell therapies and some of the bispecifics is a delayed onset of CRS. That's a small difference. And so how do we make sure self-monitoring is really hardwired into these patients? How can they identify home vitals, that monitoring, that step up? And then, hey, if we recognize something, right, either on site or that patient at home calls in and our APP is like, hey, I think you need to come in, we have that infrastructure in place where it could be 11 p.m. on a Friday because we know everyone has this occur at 11 p.m. on a Friday. And we have that intermediate care center. We can see them under an observation counter. If we need to, we can admit them, but we can take care of them right away so they don't need to abandon that therapy. And then I think at the end of the day, then building in those risk assessments for ongoing monitoring will be important. And I think when we can do that and we can reduce that CRS or treat the CRS, then we can continue that therapy and those patients can get that great durable response, whether you're going to measure it by overall response rate or minimal or measurable residual disease. So, as we talk through this real quick, maybe to my colleagues, I'll kind of turn it back. Does this process really work out with you all? Is there anything you'd like to add as we talk about this care continuum and setting patients up for success?
Yeah, I think that this is such a nice process, and very specific time points of when you touch on the patient. And so I think this looks like a really great process planning model for those that want to implement or operationalize this in their area. And by the way, don't forget we have questions that we can answer afterwards, so I think you can put it in on the app. I just forgot to remind you. So Amy, do you want to comment on this?
Yeah, so I think this is for those of you not using bispecifics and not doing CAR T, this is really a great roadmap. For all of us up here, we were doing CAR T long before the bispecifics, so this was just sort of a modification. But in the community, this is where you're going to be starting. So this is really a great platform, Ryan.
Absolutely.
Excellent. I'm going to go on to the next slide here. And talk about the integration in community. So that's a theme, right? That's a theme. And I think the difference for communities, exactly what you mentioned, is in academics, we've had exposure to CAR T, but we know communities always referred into CAR T, right? Or they form those partnerships along the way. And so now, this is a therapy that potentially can be still partnered with an academic center or a large hospital system, but also can be more independently owned for that ongoing treatment, right? And as we reviewed in follicular and diffuse large B-cell lymphoma, there's fixed duration, treat to progression. And I think, why are we integrating this in the community practice? Well, there's that reduced hospitalization burden, right? We even saw in follicular, you don't even need hospitalizations. There's more data coming out moving forward that it could be a recommendation. It increases that patient convenience. We know sometimes there's a long wait for manufacturing for some of these CAR Ts. How do we get this patient treated sooner than later? And then to me, it's the how, right? And the how is the pre-planning. It's the execution. And that's what you all do so well, right? When that patient walks in the clinic, you've worked them up ahead of time. So just as we do that, we want to do that for therapies. And we want to make sure that we're working up these therapies ahead of time, have the protocols in place, and we reduce any of that intervariability. That tocilizumab's there. Make sure that your team members are trained. And again, it's not just physicians, it's not just APPs, it's pharmacists, it's nurses, and it's those individuals that are going to be picking up the phone at 11 p.m. on a Friday that are going to be triaging this call, and they're going to be important key team members. So lastly, make sure we're providing patients with vital monitoring tools. I really think that when we think about digital monitoring and remote monitoring, that's kind of the future of bispecific care. And as we see this going to the community, how do we make sure we have validated tools that we can rely on? I'm not sure we're there 100%, but I see a lot of my colleagues starting to implement these in their practice. I think in the same regard, it's that designated contact for triage. It's a triage individual that kind of is aware of these and not just looking at hydration alone, but does they need TOSI? Will they need IVIG? Do they need to come in right away? And then how do we stand this up in the non-hospital setting is really the newness of bispecifics, right? And I think, people are moving CAR Ts outpatient. Some have been doing CAR T outpatient for a while. Some of us are starting that process, but I think getting these outpatient and building that program is truly going to be successful. And then lastly, how are we checking in on that patient? What are those high-risk periods of time where we really need to intervene and to make sure that we're standing up that standard work to intervene appropriately? So maybe, I'm not sure if there's any more comments here, but any other key takeaways from community practice that we haven't touched on?
No, you hit the nail on the head, and I think we're good on time. We're going to go to our conclusion and question and answer. Great job, everyone.
Great. So patient education, we've talked about this, just making sure that you're thinking about infections, not just thinking that every fever is cytokine release, making sure that they're prophylaxed and they're vaccinated, they have their thermometers, the wallet card, right? The one, nobody talked about the wallet card yet, but the wallet card.
Talk about the wallet
yes,
card.
the wallet, the gold card, the wallet card. Make sure they have their wallet card. And then, so highlights. So clearly more patients are candidates for bispecifics than CAR T. It harnesses the benefit of immunotherapy. The efficacy is fantastic in these patient populations. No hospitalization for FL. We've talked about the cytokine release, and the ICANS is pretty predictable, and the more of these you give, the better you get at it. So if you're not doing it, jump in and just get it done, and you'll realize that it can be done. Extended follow-up supports durable responses, and then moving into the community setting is something that we really need to be working on as academic centers. And then, so in diffuse large cell, same concepts here, but moving, it's here in second line with chemotherapy. We've got good extended follow-up data. Hospitalizations are required today unless you have a great, like, outpatient place that you can monitor them. I don't. I'm sure some of you do.
Oh, Emory.
Yes.
Standard.
Yes. So anyway, that's like the holy grail, is not really to monitor them like they're admitted, but not admitting them, but we're not there. Anyway, so limited data, infection rate is steady. And again, these are off the shelf products. So there's always a delay with CAR T. There's not a delay with bispecifics.
Absolutely. And so, oh my gosh, we get to find out who's the winner. So the Onco Challenge winning team is, cue the video. Confident Clinician.
I knew it.
Yay. Good job, everyone.
Finally, they're animated.
Look at all those sad people over there. Thank you for playing our game show. We do have a couple of questions if you have time to stay, and then we'll close out this session so you can go back to more JPro Live fun stuff. So don't forget to get your question and answer. To earn the credit, you have to go to medscape.org, Symposium NHL Bispecifics for the credit. You can also scan this QR code. Don't sit here for a whole hour and a half and don't get your credit. You have to. And we have pharmacy credit with this as well as ANCC credit. And so I will let you all scan away that code. Didn't get it, you can go to medscape.org, but I am like bad about remembering to go back, so I would just do it now.
Me too.
So that you don't forget about it. All right, and we do have two interesting questions. One was sent to us by an astute pharmacist. I won't mention her name. I don't know if she's online, because I don't see her here. Can you do the 3 step-up doses for DLBCL with epcoritamab so we can keep the patient all outpatient? Ryan.
Yeah,
Amy,
you know, I always like to speak to package insert just because, you know, for follicular, I always think, you know, you want to be thoughtful in following that 4, and then for diffuse large B-cell lymphoma, the 3. But I will say that there's a lot of data that's changing, data that's changing in terms of how quickly you can do step-up doses, how quickly you can do things inpatient or outpatient. And so I would say pay attention. I would also just give a plug. There's a lot of data probably being released later this fall as well that can build upon that.
Yeah, absolutely. And for CRS, how early do you give dexamethasone for CRS? I think there's a little bit of a difference with myeloma than lymphomas.
Yeah, I think there's a caveat in that the time frame of when that CRS occurs. So oftentimes if it's within less than 12 hours of them receiving the product, there's a little bit of a more impetus to use the dex early, but the consideration is as they move into that higher grade. So as they start having some hypotension or hypoxia, adding that in addition to some Tylenol.
Yeah. Amy, any thoughts?
Yeah, same thing. Or, you know, if they're starting CRS very early, that's a red flag. So you're going to be, you know, throwing your supportive care at them sooner.
Turn off that process, and in parallel look for infectious causes, et cetera. So, all right, I think that's it. And I wanted to thank you all so much for participating today. This was so fun for us, and I hope you found it enjoyable as well. Don't forget to claim your credit, and don't forget to provide feedback on the style of program. I think it's a little bit different than what you see in other areas, so I'd like to hear what your thoughts are. Any last words from our chair? Amy?
So I actually have a question for Caitlin about why the rates of CRS are different in clinical practice than they were in the trials.
I think that there's probably a lot more lived experience in early intervention. So I think as we've kind of come to acknowledge, I also think one of the pearls that I also like to call it, know what product you're giving, know what disease you're treating, because I think that reframes how you assess patients and where your level of caution and where you're kind of going to jump in, maybe, you know, right at that cusp, where I think that's where we're catching early CRS and managing it much better.
Yes, I agree with that. And I just didn't want people to think that maybe in clinical practice we're missing it. I just
Right.
think in clinical practice we've gotten better at managing
We're
it.
so good at
Absolutely.
it.
And all
Yeah.
disease states, yeah.
Yes, yes.
Excellent. Well, I think we
great
can conclude this program, and I hope you have a wonderful JAD Pro Live 25. Take care,
Thank
everyone.
you.
Thank you.
Thank you.